Hello, everyone. Welcome. I'm Jen Meredith, a professor of practice with Cornell University's Department of Public and Ecosystem Health and a lead for external public health education. Over the last year and a half, in support of the local, national, and global COVID-19 response, with eCornell's help, we've reached more than 20,000 people with public health education related to personal and community health and well-being, and related to emergency and pandemic prevention, preparedness, and response. As a part of our commitment to help extend public health resources and tools and to augment our collective abilities to improve public health and well-being, it's my honor to unite 4 colleagues here today to help us learn a little bit more about monkeypox. As we'll discuss, we are not facing a pandemic yet, and the virus is quite different from COVID-19, but we don't want to just sit here in the wings and hope that this outbreak goes away. As individuals, as community members, and as leaders, there are always ways that we can augment public health, and I look forward to learning more about how to do so today. Before introducing the speakers, I'd like to thank the hosts of this session, Monkeypox, Actions to Prevent, Detect, and Respond to an Emerging Outbreak. Our sponsors are the Cornell University Center for Pandemic Preparedness and Response, the Cornell University Master of Public Health Program, the Cornell Center for Health Equity, and everyone working behind the scenes at eCornell. Now, to help us learn, we have 4 amazing speakers here today with us. Dr. Emily Lutterloh trained as an infectious disease and pediatric infectious disease physician, and then expanded her focus to public health via working as an officer with the U.S. Centers for Disease Control and Prevention's Epidemic Intelligence Service. She now serves as director of the Division of Epidemiology at the New York State Department of Health. Dr. Heidi Torres is an infectious disease and internal medicine physician with the New York Presbyterian Hospital and Weill Cornell Medical Campus. And she is an instructor of medicine at Weill Cornell Medicine. Dr. Torres also serves as hospital epidemiologist with the New York Presbyterian Hospital, helping to prevent, detect, and respond to outbreaks. Dr. Keleso Makofane is a health and human rights fellow at the FXB Center for Health and Human Rights at Harvard University. Dr. Makofane is a public health researcher and activist who works in the global HIV response, including with a specific focus on sexual minority men, seeking to build power to stop discrimination and violence inflicted on Black, gay men around the world. And Dr. Jay Varma trained as an internal medicine physician and then shifted his focus to public health and the prevention and control of diseases, working for the U.S. Centers for Disease Control and Prevention in the U.S. and around the world. During the COVID-19 pandemic, Dr. Varma served as the principal scientific spokesperson and lead for New York City's COVID-19 response, and he is now serving as the director for the Cornell Center for Pandemic Prevention and Response. Thank you all for being here today. I just wanted to note that this event is being recorded and will be viewable afterwards via the Keynotes portal and via the same URL that you used to access the call today. How this will work today, I have a few questions prepared for our panel, and then we'll open it up to audience questions. You may submit questions in the chat, which you can open by clicking on the dialog box at the top right of your video player. Throughout the discussion, we'll also share some URLs of resources that we're mentioning, and you'll be able to find those in the chat. So, Dr. Varma, I'm going to start with you. Thank you so much for being here with us today. You have global experience working on communicable disease prevention and outbreak mitigation. Can you tell us a little bit about what monkeypox is and why we should or shouldn't be concerned about it?
Great. Thank you very much, Jen, for having me today. I think, it's important before we begin this talk, obviously, for people to understand a little bit about what this virus is that we're talking about. So monkeypox is a virus that humans have known about since the late 1950s, and it shares a number of similarities with another virus that you may have heard of from history called smallpox. Thankfully, smallpox is the one disease that we've actually eradicated from this earth, and as we'll hear a little bit later, that has some good news for us related to monkeypox. Historically, people around the world have thought of monkeypox as a disease primarily restricted to Central and Western Africa. And it's known to be a disease that likely lives in animals, although it's unclear which animal it is that actually carries it. It's thought that rodents are probably the most likely source. It's thought to be a disease that lives in those animals and then spills over into humans, so that when humans come into contact with them, they get infected and they can potentially transmit infection to other people. And there have been many, many outbreaks that have been well documented that have occurred in Africa, but also in Europe and the United States before. Historically, those were always traced, however, to some type of contact with animals or clear contact with somebody who had spent time in one of those areas where it's thought to be endemic. Now, as we'll hear about in a little bit, that's changed a little bit, which is the reason we're having this talk today. But let me just go for a few minutes and describe a little bit about how this disease is transmitted and how it presents in people. So monkeypox is a virus, as I mentioned, similar to the smallpox virus. And the primary way that it's transmitted from one person to another person is through direct physical contact. As I'll discuss in a moment, one of the characteristic signs of this virus are, marks or changes on your skin, essentially a rash. And the primary way this gets transmitted is when if you have this infection, have a rash, and you have direct physical skin-to-skin contact with somebody else. And for those of you who had children before the era when we had a chickenpox vaccine, you may be familiar. Again, it transmits itself somewhat similar to a chickenpox is through that skin-to-skin contact. Now, of course, that is not the only way it transmits. And so we are concerned about other possible routes. One is, it is possible for this infection to be transmitted from one person through another through the air. From everything that's been studied so far, it appears that that only comes from very close range contact. So it doesn't necessarily spread over a long range, but you have to be in very close proximity to somebody else. The second way it can also be transmitted is through contaminated clothing or linen. So if somebody is sick with monkeypox and they use a towel and they rub themselves with it, it is possible for the virus to go from that towel then to your skin if you share that towel as well. So as we'll hear a little bit later, it's very important when people are isolating to not share, linens or towels with each other. So now if you get exposed to monkeypox, what happens? Well, like a lot of viruses, there's what we call an incubation period. So there are several days between the time when you are first exposed to this virus and the time when you will actually first potentially develop any symptoms. That period, again, what we call an incubation period, is thought to be somewhere between 1 to 2 weeks, but it can also range as far out as 3 weeks itself. And during that period, you don't have symptoms and the person is not contagious to other people. Now, after that period of, again, usually 1 to 2 weeks, you can develop flu-like symptoms. So this includes a fever, a headache, you may just feel generally tired, you may have a sore throat or cough. It's also very characteristic, it's swelling of your lymph nodes. So you'll have swelling in some part of your neck, your armpits, or your groin. And this is a period when people can potentially transmit infection to other people. So after a few days of that, what we call prodrome phase, then is when you normally will expect to see the classical presentation of a rash. And as we'll hear about in a little bit from Dr. Torres, the rash has a description from the way the virus is thought to be when there's usually, human contact that started maybe in animals, and how we're seeing it now, which is a little bit different in its locations. But the most important thing to understand is, this is a rash that goes through several phases. It can start off as a dark mark and then grow into something that looks more like a bump with pus in it. And we'll see some pictures about this a little later on so you can understand. The most concerning part about the rash is really that this is where you are most infectious. You can spread the infection from one person to another. And it's very important for people who have that rash to keep their skin covered and to limit the amount of contact that they have with other people. Medical providers can diagnose this infection. We'll talk a little bit later. You'll hear from our New York State colleagues about the way to get diagnosed for this. But the normal way that physicians use to diagnose this is that they will use a swab, similar to what many of you may be familiar with from COVID, a swab of one of these lesions. They'll brush it and they'll put it in a tube and they'll have it sent to a lab for testing. There are other ways to test for this that we can talk about in a little bit, which may include swabbing the throat, taking samples of other body fluids, and other tests that may develop in the future. So far, there is no direct treatment for this infection. There are new viral agents that have been used previously to be approved for the treatment of smallpox, but there are no medications that we know of that are known to be proven to be effective, although there is research that's going to be happening on offering people treatment for it. The good news, however, is there are vaccines that can both prevent infection in people who've never been exposed, and if you have been exposed and you get vaccinated soon enough, can also prevent you from developing severe disease. One of these vaccines is the original or a modification of the original smallpox vaccine. And the other one is a new vaccine that is just, as you'll hear in a little bit, is just now starting to be administered here in New York City that is approved specifically for the prevention of monkeypox. So I'll stop right there, Jen, because I think that's a decent sort of brief introduction to this virus, and we'll hear more a little bit later from our other colleagues.
Yeah, excellent. Thanks so much for that overview. And before we sort of narrow down to what we're seeing in New York State and how the virus is presenting, just a question. Had we not experienced COVID, would we be talking about this monkeypox outbreak right now? Meaning, are we in a high state of alert about emerging disease outbreaks because of the impact that we saw of COVID? And is this at all like that? Or is this something that we are only really aware of because of the experience from COVID?
Yeah, I mean, I think the big picture here is for people to recognize that we are unfortunately in an age of pandemics. For a number of different factors, diseases are emerging more quickly than ever. And because our world is more heavily concentrated in cities and we have more migration, both the volume and velocity of people moving for travel or for relocation is increasing. So we're going to continue to see new diseases like COVID-19 and monkeypox emerge. What's concerning about monkeypox, and the reason we're all here on this webinar today, is that the virus is demonstrating a new pattern. Since the past few months, there have been initial outbreaks detected throughout cities in Europe where monkeypox is not normally seen as an infection. And these infections have occurred almost exclusively among men who report having had sex with other men. And many have reported going to play parties or bathhouses or places where they had sex with potentially many different partners. And what worries us about this is that many of those people from those initial investigations can't recall specifically who it is that they interacted with that gave them monkeypox. And the reason that's concerning is it suggests that there's transmission going on where people don't know that they had the infection and they're at risk of getting it to other people. The first case was officially diagnosed here in the United States in Massachusetts on May 17th. And now there are several thousand cases that have been diagnosed around the world. Many of them obviously continue to be in the places that are endemic in Central and West Africa, but places like the UK and other places in Europe have experienced hundreds of cases so far. So even if we hadn't been through this COVID-19 experience, this is something that we in the public health world would be concerned about. And what really concerns us is this point that I raised before, which is that all the data indicate that both here in the United States and elsewhere, that the number of cases that is officially reported is an undercount. And the only way that you can really get ahead of an outbreak and prevent people from being sick and having complications is to have a good handle on all of the cases. So that's really, I think, the most important reason we have everybody here today. It's really important for people in the health field, or if you have people in the affected communities, or if you just care about your fellow citizens and want to make a difference, to be aware of what's going on, because we're only going to control this outbreak if we're all heightened in our awareness and understanding of it.
Excellent. So Dr. Lutterloh, I think that's a really nice segue over to you. So you lead New York State's Division of Epidemiology, which is the team that detects and tracks and investigates disease outbreaks. What are you and your colleagues across the country talking about, and what are you concerned about related to monkeypox?
Well, right now we're trying to get the word out about it to both the general public and also clinicians. This is a case where knowledge really is power, because Jay gave a very nice summary of how it's transmitted. And if you know how it's transmitted, then you can adjust your behavior to do your very best not to not to become another case. So we're trying to get the word out to the the general public, particularly the community that's most affected currently, and also clinicians, because when someone who has the clinical symptoms or signs consistent with monkeypox and the epidemiologic risk factors, we want the clinicians to pick up on that and send them for testing. We do have testing capacity to test those people, and we want to test anyone for whom it is indicated. So that's what we're doing now. We're trying to get the word out so that everyone knows what this is and how it's spread, and what to do if they if they think they might have monkeypox. When we typically hear about cases from the local health departments, because the clinicians are told to call their local health department if they see someone that they think might have monkeypox. So when we hear about a case, we talk to the local health department and explain to them that what needs to be done. For example, talking to the individual who may have monkeypox, finding out about their contacts, where what their history is, where they think they might have gotten it. We also help arrange for testing, and if an individual is identified as having monkeypox, then we can help find out if their contacts need vaccine. We can help arrange vaccine. We can talk to them about the possibility of treatment if someone is quite ill with it and needs some of the investigational treatments that are out there. So those are really the things that we're doing. We're in the phase where we are trying to draw a circle around this and prevent further spread.
So just a follow-up question on that. You talked about getting the information out broadly, and knowledge is power, and that's so consistent with, I think, what we learned with COVID-19. At this point, are there certain geographic areas or certain communities that you are targeting specific outreach with?
Well, let me just run through the numbers here. Right now, there are over 3,500 cases outside of non-endemic countries. And, we can't forget those endemic countries. This is a point I think we have to go back to. It's, there are many, many more people who suffer with this and have suffered for many decades in the countries where you see this all the time. But right now, we have over 3,500 cases outside of that area in 44 non-endemic countries, mostly in Europe. We have at least 172 cases in the US, and I think the most recent update is 42 in New York, with 39 being in New York City and 3 outside of New York City. So I think an important point to remember here is that although right now we're seeing cases primarily in the community of men who have sex with men, just like we all know that viruses don't like to stay put geographically, when spread occurs, it doesn't necessarily always stay within a community. So knowing how this is spread and knowing the appropriate prevention measures is appropriate for anyone. Now, having said that, of course, right now it seems to be primarily the community of men who have sex with men who are mostly affected. So yes, we certainly would target our communication materials for that community.
So that's really great insight, and it sounds like you have really great communication with peers across states and into other countries. Dr. Varma talked earlier about the exposure period and the incubation period, and then the emergence of symptoms and or rash that might be days or even weeks beyond exposure. Presuming that there might be some clinicians, some public health practitioners, some parents, some caregivers, some lovers with really good eyes. What are some things that you would advise clinicians and all of us involved in public health to take? What do you want us to be aware of, and how can we support New York's response in preventing, detecting, and responding to COVID-19?
Well, right now, I think the most important thing to realize is this is not COVID. The transmission is very different from COVID. And, for most people, right now, this is something to be aware of. This is not something to be worried about. We don't know yet what the outcome is going to be. I mean, I think many of us are still hopeful that we can bring this under control so it no longer is circulating in the US and elsewhere. We don't know that will be the outcome. I mean, it's possible that we will have remaining low levels of circulation. We're certainly doing everything we can to prevent that. I think we have to be careful to reach a balance where we want to use the lessons learned from COVID, but at the same time, this definitely is not COVID.
Great. So I think one of the lessons learned that we had from COVID was the importance of, if you become aware of symptoms, to seek testing. So Dr. Torres, I'd love to sort of shift the conversation maybe over to you now. Of what you're on the front lines diagnosing and treating communicable diseases. What should we be looking for? What kind of signs and symptoms are presenting? And we've heard in the news, and Dr. Varma talked about this, that maybe the way monkeypox is presenting now is a little bit different from what we may have seen previously in textbooks.
Yes, absolutely. So I think classically what we're taught, or what we've seen historically, is that patients will typically develop what we call a prodrome, or early symptoms. And these symptoms include things like fever, malaise, headache, sometimes sore throat, sometimes cough, swollen lymph nodes, and that's later followed by a skin rash. What we're seeing now is a lot of patients are presenting with a skin rash as the first sign or symptom, which means that other cases, and historically cases without these initial symptoms, we would kind of discard or think it's not likely monkeypox, but that's different than what we're seeing these days. These days, sometimes patients will first develop the rash, and then they may or may not go on to develop these other symptoms days later. I'd say that's the first key difference we're seeing compared to historical cases. The next key difference is where we're seeing the rash on the body and how we're seeing it develop. So typically after those first prodrome lesions would appear, would occur, we would see lesions start to spread over the body after a few days. So we would expect to see lesions develop in the mouth, and then on the face, arms, legs, usually the extremities, where they would concentrate kind of on the periphery of the body and they would move inwards. So that's what's typical. And classically, these lesions have a pattern of progression, which is usually a macule, which is a flat surface that's usually red, and that will turn into a papule, which is a raised lesion, and then eventually a vesicle, which is filled with clear fluid, and then a pustule, which is just an area filled with pus or cloudy fluid. We would usually see in about 24 hours of these cases historically, the rash spreads to the entire body. But now we're seeing things a little different. So now we're seeing that these lesions may appear first in less typical places like the genitalia. So we're seeing lesions presenting initially on the penis, vagina, or the perianal region. And some of these lesion locations are coming with different symptoms. They're presenting with different symptoms. Some of these unusual symptoms are tenesmus, or the sensation that you have to have a bowel movement, even though you already did or don't have to, similar to that urinary frequency we see with UTIs. Another symptom we're seeing with these lesions in this area is bloody stools or blood from the rectum, or drainage from the rectum. So the location of these lesions in an atypical part of the body is also presenting with these atypical symptoms associated with that part of the body. The rash can go on to spread to other parts of the body, but it's sometimes seen that it's after the lesions appear in genitalia, and it's much less than usual. It's not the diffuse, heavy pustular rash we're used to seeing in those historical pictures. It's a few kind of scant lesions here and there. Eventually, whether no matter what part of the body these lesions appear on, they do eventually progress after this typical pattern of, papules, macules, papules, vesicles, and pustules. They'll eventually go on to form scabs, and then the scabs will fall off and you'll get your healed skin. That will usually happen in a matter of a few weeks, so 2 to 3 weeks. And usually, like it's been said before, most of these cases are mild, and a lot of them self-resolve, and these lesions often do resolve on their own after a matter of weeks. So that's, I think, the second part of this outbreak, how it's presenting with not so much a common prodrome, and then also on top of that, the lesions are appearing in different areas. And it's something important to note that because these lesions are appearing in genitalia, the first person the patient might go see is someone for STD testing. They may walk into an STD clinic or a private health clinic. So we have to have a lot of awareness that this may look like something else, but monkeypox has to be really high in the differential whenever this happens. So we have a few photos we could go on to look at just to give you guys a few examples. The first slide is there. Okay, great. Alrighty. So the photo you guys should be seeing right now is from the New England Journal. So this was actually a case that was seen at Mass General, I believe. So I'm going to show you about 12 photos from 3 separate cases. All of these cases are in fact from the 2020 outbreak. So they're not historical photos. They're more recent photos. So the next few photos are going to belong to a case from one patient who was seen at Mass General. And the lesions you can see here are, like we said, very few lesions on the shoulder. And there's a close-up that shows this kind of very small vesicle pustule that's tiny. So like I said, a lot of these lesions would be much more diffuse, much more full body, even a little larger historically. So I'll give you a few facts before we go on to the next photos of this case. But this was a young male who presented with about a 9-day history of perianal painful lesions or itchy lesions to begin with. He went to seek treatment. He first was screened for STDs and he was treated empirically or automatically for STDs. He didn't have any improvement. These genital areas or the perianal lesions, they got worse, and he developed, after a few days on this therapy he was given for STDs, he developed discharge, anal discharge, and mucopurulent discharge, followed by fever and night sweats and chills. And then also that sensation of tenesmus, that desire to have a bowel movement. So after a few days, the rash spread to other parts of his body, which we'll see in a second. But again, it goes to say this rash in this patient presented in an atypical area, and then it went on to spread to the rest of his body, but in a very diffuse, minor way. We can go to the next slide. So a few days later, I think these were actually the last lesions that appeared. You can see that there's 1 or 2 very tiny lesions in his palm, and there's this vesicular pustular lesion on his finger. So again, the extremities of the body, which we would first expect to see early on, were some of the later areas to actually have the infection spread. I do want to make a small note. Some of these photos are going to include genitalia. So if you're in a public place or you have any small children around, just want to be aware. All right, go to the next slide, please. So these are the initial lesion, or one of the initial lesions he appeared with. So in the first panel, you can see that there is at the very top of the anus, you can see an ulcerative lesion. So that's the initial lesion he presented with. And it was first described as itchy white spots, but then it progressed to this ulcerative lesion. You can see next in this panel B and C that he had this ulcerative lesion on his penis, and it had very well-defined borders with kind of an empty center. You can go to the next slide. So this is a separate case from the UK. There's not a case report attached to this, so there's not too many details known, but you can see at least that these lesions, again, are pretty scant, a little smaller. These seem to have progressed more to the scab period of that progression. But you can see a few on his hands, a few on his chest. He also had a few in the groin area, and then a few on his face as well, and other photos that we didn't include. You can go to the next slide. So this is a case that was also reported in New England Journal. This is a case from Portugal, I believe. And this patient also presented again with a rash that was macular or flat. You can see in panel A on his groin. He also had associated lymphadenopathy, which is one of the signs that is seen with monkeypox. And he had painful lymphadenopathy, and then it later progressed to these ulcerative lesions you can see on his penis, and they're also surrounded by a few pustular lesions. And next slide, I think that may be our, oh no, one more slide, okay. And yes, so this is the same case, and then these are a little bit more detailed, the penile lesions he went on to develop further. So you can see almost a confluescence or emerging of some of these vesicular pustular lesions near the head of the penis. And then at the pubic area, you can see more scabbing and dried out lesions with kind of spread to that whole area. All right, so I think that, like we mentioned, it's important to note that these lesions can present in a different part of the body. So it's important when you make your differential as a provider, or even just to be aware as a patient, you have to, it's important, and we want to spread awareness that this is really circulating. And again, it's overall low risk, but it's circulating. So we want providers as well as patients to be aware that this is something that should be considered. As Dr. Varma said, this is a key moment with this disease because it's really the opportune time to identify cases, to diagnose them, and to prevent and contain this infection while we really get a chance. You know, I can, go ahead.
You know, that was just such a great overview, and the images really brought some sort of reality to what this is. I think Dr. Varma and Dr. Lutterloh both mentioned that thus far we're seeing, in the US, we're seeing monkeypox mostly among men who have sex with other men. Is there any reason to believe that transmission will stay that way?
I don't think so. I think that the transmission methods remain the same, regardless of how they're presenting. It's, you know, different, but the transmission methods are, as Dr. Varma said, it's through skin to lesion contact. So, you know, bare hands or, you know, any skin contact with these lesions, you know, whether they're genital, whether they're on shoulders, arms, face, what have you. Intercourse is just one of the many methods that you can have prolonged skin-to-skin contact. So, you know, anyone who comes into contact with any lesions in any other part of the body is also at risk. You know, it's also related to contact with any contaminated material. So if you have bed sheets, towels, linens, things like that, you can also become infected. And then via respiratory, because of lesions in the mouth that can secrete that virus with prolonged face-to-face contact between an index patient and someone else. That's another method. So yes, it is circulating in this community now, and we hope to raise awareness. And, you know, patients who develop genital lesions may also be more likely to seek evaluation because it's a delicate area. But there can be many cases going undiagnosed, you know, in other populations or in the same group that are on other more benign parts of the body that get disregarded and never really come to our attention. So even if it is circulating in this group now, any one of us, you know, could potentially be at risk if we are exposed in any of these methods.
Funny and his perspectives and his additions to the conversation. But there's a couple of questions that the audience has shared that really relate, Dr. Lutterloh and Dr. Torres, to what you've talked about. So Dr. Monkeypox, I beg your permission to jump in with a few of these very clinical questions first. So one question is from Gerard. Can monkeypox be transmitted during the prodrome period?
So, you know, I welcome input from Jay or Heidi. I think the latest I've heard is that's not really completely known yet. You know, I certainly wouldn't put it past this virus, but you know, we have a lot yet to learn about this virus.
Yeah, just to clarify, the prodrome is, for everybody, is that period when you have these flu-like symptoms without any visible skin rash. And yeah, as Emily said, it's not known, but the assumption right now is that you are potentially at risk of transmitting. You won't be as infectious as others. But again, we're still learning how true that is and how infectious people actually are. It's safe to assume people might be infectious.
And then sort of another question sort of linked to that from Charles. Is there a high likelihood of scarring?
I don't think that there's a high likelihood of scarring. We do see it in some patients. I think since these lesions are also smaller than historically, there may be a chance that it is less likely. At least in some of the cases I showed in some photos that are available, these patients healed completely without any major, skin changes. So I think it may be early to say in this outbreak, but there's a possibility, but I would say that the majority of cases do not have significant scarring.
Okay, so those are great questions for the audience, from the audience, and I encourage you to keep putting those in. Dr. Makafane, I'm gonna shift over to you now. So you're a health and human rights scholar and an advocate, and history shows that diseases impact different communities differently based on resources that they have access to, vulnerabilities due to underinvestment and/or structural racism and stigma. As you have watched the global public health leaders start to talk about, track, and communicate about monkeypox, what do you think is being done right so far?
Well, let me start at a different place. A friend of mine came back from a trip to Europe where he had sex a few weeks ago. And last week, so not this past weekend, but the one before that, he had been experiencing fever, some of the swollen lymph nodes. So on the Monday, he goes to his primary care provider and says, I think I have monkeypox. This is the number of days since I've had sex. I went to this European city, which is known to have an outbreak. And I would like to get tested so that I can access whatever kind of supportive treatment is to be accessed. Doctor does an STI screen and doesn't test for monkeypox. And basically says, let's wait and see what the STI screen says. STI screen comes back clear. And my friend now goes to the urgent care because he's starting to experience pain in his rectum. He goes to urgent care and he says, I think I have monkeypox. This is what I've done with my doctor. This is where I was over the past few weeks. This is what I did. This is the kind of sex I had. And the urgent care people don't offer him a monkeypox test. So he ends up going to an emergency room in New York City at a big academic hospital. Sits in the emergency room, tells them the same story, I need a monkeypox test. And they don't give him a monkeypox test. They give him a CT scan. The clinician who was dealing with him entertained the possibility that he had cancer and shared as much with him, but didn't entertain the possibility that he had monkeypox. And so my friend had to leave that hospital in pain. And the pain had escalated to the point where he actually had to find and use an opioid to manage it, while he was then dealing with his primary care provider to help him with the pain management, which the primary care provider eventually did. My friend eventually got swabbed at an urgent care, so the fourth provider, on Monday, and I think still does not have a result from the lab today here in New York City. So that's a reality. And there is a certain kind of denial if we talk about monkeypox as if it's possible right now to go to your health provider and get the test you need or get the help you need. My friend is a scientist. He's a PhD in some biomedical science. And he is knowledgeable and he advocated for himself. And it took him 8 days to be swabbed for monkeypox. He still doesn't know whether he has it, whether he has orthopox or not. So it hasn't even gone to Atlanta for the actual monkeypox test. So what's been great about the response has been that really government agencies, I think, have reached out very early to activists and the other way around. And they've been really open conversations about what to anticipate, how to communicate about monkeypox. how to think about stigma. Testing has not been good. And I think we should acknowledge that. I think we have to acknowledge it for us to become better at it. New York City has been running something like 20 tests a day in a city this size for monkeypox in the middle of an outbreak. So that's not been great. Vaccination had not been really mentioned as something that was coming online soon, though we'd been in meetings for weeks. It dropped yesterday in one site in New York City. The site ran out of vaccine and no one can get an appointment. So that seemed like an opportunity to have engaged and to have really planned, had the community plan and anticipate and think about how to access vaccine, who needs to access vaccine, whether all of us have the same need or there's some of us who should prioritize getting there first. None of that has happened. So there's a reality here which involves a lack of urgency around fixing these issues that had been identified weeks ago. And a kind of the momentum we had been building in the close collaborative talks we'd been having feels like it's stalling at the moment. So to me, it's really important to kind of firstly just deal with that reality, just to say it and to accept it, to accept that things are not going well, to accept that we have no idea how many people have monkeypox because New York City has been running 20 tests a day in a city of this size. And that I know people, I have asked for a monkeypox test, it was denied. I have friends who have done the same thing. And we have someone who was in pain, didn't even get treated for pain. And it took him a week to get tested for monkeypox. So I think that, again, it's a good time to take stock now. I don't think it's going well. And I think that we are going to have to engage the community, not only to message well, but to hold their departments of health accountable, to hold their healthcare providers accountable, to educate the healthcare providers, to not expect that it will be easy to get what we need and that we won't be humiliated by being passed from person to person. The hospital that he went to, the doctor couldn't even give him a visual exam because the doctor said they didn't have anoscopes there. So they weren't prepared to look at people's butts at that hospital, even though some really important things happened there. Mm-hmm. So I think there's just a level of a lack of urgency, a lack of seriousness about making sure that the claims we're making about testing are true, that in fact healthcare providers know what to do, know that if they don't see a characteristic rash, the person might still have monkeypox. It's like the symptoms are changing so fast that, at this point, if a gay person says, I think I have monkeypox, you should treat them as if maybe they have monkeypox. Yeah. So sorry, I've gone on. Like, I think there's just a time for a reality check, and we're at that.
Yeah. No, I think your input is great, and there's so many questions that have now come up from this, and I just wanted to interrupt for a second, and then I'll come back, and I'd love to ask you to talk to us more about advocacy and outreach and communication. Dr. Lutterloh, Dr. Varma, are you able to talk more about what Dr. Mokafane was talking about of sort of access to testing, access to treatment, access to, or clinician access to the information that they need? What do you see going well, and where do you see, or how do you see that we can sort of shift focus and shift investments to make it more accessible?
Maybe I'll talk. Maybe let me talk about the national level first, and then I'll shift to Emily, maybe to talk about what New York State specifically. I wrote an op-ed in the Washington Post earlier this week with another colleague, Jennifer Nuzzo from Brown. We've been quite concerned that the movement at the federal level has not been as fast as it should be related to diagnostic testing, and this is really an issue that needs to be primarily addressed at the federal level between CDC, FDA, and Center for Medicaid Medicare Services runs CLIA, there are a number of pathways by which they can help to make sure that commercial laboratories as well as hospital laboratories can develop their own in-house tests, what's known as laboratory-derived tests. But to do that, they actually need technical guidance. They need some, indication from the FDA about, the way they will or will not be regulated. And they also need actual material to make sure they can validate those tests themselves. So there has not been enough motion on that. There was an announcement yesterday that now 5 labs across the country will have this, commercial labs, but it needs to be far more than that. That's for diagnosis. Treatment remains a challenge just simply because the drugs that are available are not officially approved for monkeypox. And even if they are, there's a limited supply. Nevertheless, there is a real need to make sure that the access is scaled up because we need to know how useful this is or not. And I think the same is true with vaccination. I know the federal government has placed a large order of this Jynneos vaccine, but we really need much better transparency from the federal government of how many doses are actually available. Because as Coletto mentioned, there was this massive line at the health department site where people couldn't get vaccinated. That's not a failing of the health department, it's a failure of the supply chain.
And if I could jump in about the testing, Dr. McAfee, what you said about what your friend had to go through, I never like hearing any story anywhere, anything like that. It's very disheartening. I think it speaks to the importance of getting the word out to clinicians about what the signs and symptoms are and when they need to send someone for monkeypox testing. And we're doing what we can to try to make that happen. And I think one good thing is, this is the community that's affected now is very good at being activist and making sure that that we know when the word isn't getting out there. So we're doing our best in that regard. And if I could speak a little more about the lab testing capacity, when back at the beginning of COVID, we had so many people that we knew needed testing and we wanted to test, and we just did not have the test to do it. Right now, we're not in that situation. Right now in New York State, we do have lab capacity. Now, to get at your point that, more people certainly probably need to be tested. That's a very good point. But, even with that, right now, we're not at capacity. So, we need to make sure that the providers know when they should seek testing and how to seek testing, and that's what we're doing and trying to get the word out. Both us and we're New York State, New York City. Department of Health and Mental Hygiene also has been doing a lot to get the word out. So hopefully we won't hear more stories like that. Wadsworth certainly has capacity. New York City Public Health Lab is also testing. And then Jay, I think you brought up the fact that very shortly, I believe 5 large commercial laboratories will be brought on board, which should make it a lot easier for clinicians to order testing. And also Jay, you talked a little bit about bringing other labs on board and the other types of testing and the need for validation. That is very important. I mean, we want these tests to give people the right answers, and that takes a little time, but obviously we need to minimize that time to make it as easy as possible to increase the number of tests that we're doing.
Fantastic. So Dr. McAfee, I'd love to shift back to you because you talked, thank you again for raising this urgency and for sharing the experiences that you're seeing on the ground. And so I'll pose the question to you, and then Dr. Torres, I'd love for you to jump in on this as well. How do we raise awareness? How do we as citizens use our voices to help advocate? How do we help make sure that the resources are in the place that they need to be? The resources, including knowledge, awareness, acknowledgement.
Yeah, I think there is a need, and some of this work has started happening for community-based organizations and anyone who serves men who have sex with men, gay bi men who have sex with men, to really equip themselves to communicate about monkeypox and to start to figure out how people are going to get tested and how people are going to vaccinated and how people who might need treatment will get treatment. So I think at this point, community-based organizations really have to rally and get themselves prepared, because it might happen that these interventions are brought online without consultation, and we should just be ready for that. So that's one thing that I think needs to happen. I think as the public, we should just be aware of monkeypox, and we should not treat it as if it is, we should not talk about it as if it's a mild disease. My friend was in a lot of pain. He had to take opioids to manage that pain. He couldn't sleep. So it's not trivial, and it's also scary, and it's scary. And then you're with the provider who doesn't believe you, or who's maybe slightly homophobic, or maybe who just doesn't want to call, doesn't want an extra step when dealing with ordering tests for a patient. So there are all these things that are kind of like stacked against us. So I think, yeah, the CBOs need to get prepared. As individuals who are watching, we also need to keep clued up about monkeypox, and to make sure not to treat it as if it's not a serious illness that is a threat to the health of a very big group of people right now.
Thank you. And so, Dr. Torres, building on that and looking around, as a hospital epidemiologist and as a practicing clinician, are there things that CBOs can be doing? Are there things that Department of Health, CDC could be doing differently to help increase awareness and, flow of decision making, if you will, or a flow of diagnostics when somebody enters into a clinical setting and experiences or shares what Dr. Makofane mentioned before?
Yes, I agree. I think that part of I never like the burden of any disease to be on the patient. But I think in this situation, as awareness rises, I think individuals and patients have to have a lot of knowledge and awareness and suspicion, and to bring that to the attention of their healthcare providers. I think the best way to facilitate this process is, one, by raising awareness, by making sure that the providers that are going to see this first, whether it's ER, whether it's STD clinics, whether it's HIV clinics, what have you, those early people are provided with enough knowledge, with enough awareness, and then also with enough tools. As Calypso mentioned, it's scary to raise the question as part of your differential, because that may mean that you have a mountain of work to do and a million phone calls, and you might eventually also get a no from the City Department of Health. And I think those conversations are already being had. For a fact, I know that CDC is aware that we're not testing enough people, and they're working to break down those barriers with more local GOH, so we are able to increase testing so we can get answers, and to make it also less scary for those providers as we disseminate these tests to more smaller spaces and more local areas. So the process is much easier, it's much simpler, and it's not 10,000 phone calls. So I think those are some of the biggest steps we can take as we start to get this program going.
Excellent. So Dr. Makofane, looks like he has a response, which is great. And I'm just going to seed a question from the audience in case it bridges with what you're going to mention. Naya asks, how do we raise awareness without furthering unjust stigmatization?
So I wanted to firstly say that one important part of what Dr. Torres just said is that sometimes the answer is no. And that is at odds with saying that testing is available to everyone. So if sometimes your provider might request a test for monkeypox for you, but that request isn't necessarily going to be affirmed or realized, then it means that it's not that accessible, and that if providers have discretion and they can save themselves a little time and energy, then maybe they might and push the problem onto the next provider. So that's an important thing to talk about, that is not consistent with the idea that testing is available to everyone. How can we sensitize people without being homophobic? I think is to firstly really think carefully about what you want to say, because it involves sex, and there's a lot of stuff that comes with sex and how we each think about sex. So you really have to pause and think about like how you're framing pride, whether you're thinking of pride as this threat to the community because they have sex there and there's this disease that's going to take them out, or whether you think about pride as a celebration, which is also a political tradition, which is also a time for people who don't have queer people around them all the time to be surrounded by queer people for a week, for a weekend, to celebrate after having 2 years of 2 really difficult years with real losses. People lost real people. And so now we have an opportunity to be with one another. And then there's this thing which is threatening us. So I think just being able to recognize that this is an important group of people, that there are important occasions, important activities that they do that you don't understand. Maybe you do, but it's okay either way, because what we really need to make sure of is that we completely we affirm everyone's humanity and we do the best we can in terms of everyone's health. So I don't have like this is what you should say to avoid being homophobic when you try to sensitize people. But I think that really being empathetic, just trying to understand what your own thoughts are about sex between men, and how they might affect how you think about the risk that you are responding to as someone who works in public health.
Thank you so much for sharing that. And I'm coming back to what Dr. Torres said as well, which is, really the modes of transmission are simply skin to skin contact. And if we can be focusing on modes of transmission, that's really what we want to be supporting around. Okay, so we have about 3 minutes left. We have a few great questions. This is going to be like a lightning round, but I'm just going to ask a couple of people for some yes or no answers. From what we know now, can we get reinfected with monkeypox?
We don't know the answer to that, is my answer. It's probably you have immunity for some period of time. We don't know how long that is.
Thank you. If Jeff asks, does a smallpox vaccination as a child many, many years ago provide protection against monkeypox?
Probably some, probably not complete. The exactly how much is unknown.
Okay. Is there anticipation that monkeypox will mutate, making the current vaccines that we have available less effective or not at all effective at some point?
I don't, I don't think that's top on our list of worries. I mean, I know everyone is sensitized to that issue because of what happened to COVID, but that's not what we're expecting, at least at this point in the pandemic with monkeypox. So I would say a tentative no.
Okay, I'm going to loop two questions together here, which is a specific question from Cordella is there specific public health information for hotel housekeeping staff? So I think this is a really great question of, populations who are potentially more in the front line, more at risk, as I think Dr. Farmer, you mentioned before, exposure to clothes and to fabric, to sheets, for example. The follow-up, the complementary question is from Terry, is what can we use from our knowledge about COVID-19, or I might say from other communicable diseases, to apply to help stop the spread?
I don't know if there's specific dedicated information for people who might be exposed in that manner or at risk in that manner. The CDC, I think, has general information that's probably applicable to most things. What I can say from exposure to healthcare providers is that shaking of sheets from contaminated lesions can contain viral particles and can toss them up into the air for a short duration of time, which is why we recommend to healthcare providers in these situations with confirmed cases wear N95s. This is challenging to apply outside of the hospital because you would have to be tested for an N95 properly to consider it worthy. So I don't know if I have a specific answer, but if you have any suspicion that anyone staying in any area of your home or a hotel could have been infected, gloves, using to touch contaminated things is best. And at least a surgical mask won't hurt you. It may not protect you fully, but it is some form of protection.
Great. So masks and gloves, many of the things that we use for preventing spread of other communicable diseases. Okay, the last question that I'm going to ask is from Anna. Are we concerned about seeing increased severity of monkeypox cases in the MSM population? And that question is asked given prevalence of HIV or perhaps other STIs.
Well,
Eddie, do you want to answer that maybe, or Emily?
Jay, go ahead if you'd like to.
Well, yeah, I would just say that there's to date, the good news so far has been that from what I've seen in the data from Europe and North America, there have not been any cases of people who had to require either intensive care unit hospitalization or die. That said, let's also keep in mind what Dr. Monkeypox said about personal experience and what we know. This is not a pleasant disease necessarily to have. And there's also a lot that we don't know from the outbreaks that have been reported in Africa before. There was much more severe illness reported. Primarily that was in young children. And I think there's still some concern about people with HIV. And obviously that is a big concern given that a lot of the same people who are getting infected gay by MSM are also at higher risk of HIV infection as well.
Okay, so with that, we are at time. I want to really thank my panelists, Dr. Lutterloh, Dr. Torres, Dr. Monkeypox, Dr. Varma. For those of you who are interested in learning a little bit more, please check out the links that are in the chat. U.S. Centers for Disease Control and Prevention and World Health Organization, as well as New York State Department of Health and New York City Department of Health, all have active pages talking about or tracking and talking about what we know and what we can do about monkeypox. So please continue to pay close attention to those. And I'm just going to repeat what one of the panelists said at the very beginning. Our goal right now is to get the word out because knowledge is power. And let's also pull from what Dr. Monkeypox said, which is let's keep talking about this, keep advocating for it, that we have the resources that are needed to prevent, detect, and respond to monkeypox. With that, thank you all so much.